Great. Hi, everyone. I'm Jeff Segal. I'm both an attorney and a physician, founder and CEO of Medical Justice, focused on keeping doctors from being sued for frivolous reasons, as well as addressing a host of conflicts that doctors find themselves in. And today we're going to talk about the uncommon and unnecessary topic of how to handle angry patients, in particular legal tips, but also practical tips on handling angry patients and how to keep the stuff from hitting the fan. I'm being facetious. This is not uncommon. It does happen. And it's the bane of our existence. You can make 99% of patients happy, but that 1%, that one individual that is unhappy can make your life a living hell. And because we're healers and not fighters, we take it very personally. So let's dive in. Conflict. It is part of our human condition. I wish we could be done with it, but it exists. What we don't want to have happen is 1% of our patients occupying our entire brain. To the extent those individuals are tenants in our brain, we want to evict them, and how to evict them gently in a way that they do not create lasting harm. All right, so the first step is identifying if someone is likely to be a problem down the road. Preventative, to make a good diagnosis in advance. So the first step is this patient bad-mouthing other doctors and saying that you walk on water, you're the best thing since sliced bread? Well, I fell for this. In my first year of practice, I was a new neurosurgeon. It's when I believed I was my smartest. I was not my wisest, but I believe I was at my peak in terms of intelligence. And a patient came in and talked about these three other butchers that had just destroyed them, but they had heard so many positive things about me, and surely I could help them. Did I take the bait? I did take the bait. And who became the fourth individual, that fourth butcher? Well, that would be me. So if somebody is beating up everyone else, particularly if you're early in your career and they come in and they say you're the best thing under the sun, be careful. There's a pretty good chance that you will be that next butcher. Also, in terms of identifying trouble, pay attention to your staff. You've got one set of eyes and ears, but if you deputize your staff, you have multiple eyes and ears. And I'm a fan of the one person red flag rule, which means if one person gets the willies on a particular patient because of an interaction, pay attention to it. It doesn't mean that they get a chance to veto every person coming in, but it just means you should pay attention. Sometimes a prospective patient is on good behavior, maybe even their best behavior with you, but when they're interacting with the person making appointments, billing, the nursing staff, etc., they're on their worst behavior. And so if that's the case, remember, you're working with a team. You've got to manage a bunch of other employees. Once this patient is long gone, you'll still have your employees with you. If your employees are not delighted with how you handle this, you may lose some of your best employees. So I'm a fan of listening to your staff, one person red flag rule. All right, so here's a prototypical example. In a sense, it's almost hypothetical, but the patient was rude to an employee on the telephone, was very difficult with the individual collecting money. The patient would schedule, then reschedule appointments. I mean, you could see the writing on the wall here, but when the patient came in, loved the doctor, thought the doctor was wonderful, walked on water, was a saint. Then she had a procedure, and then all of a sudden the doctor turned into Satan. So could you see this coming? Yes, you could see it coming because of how the patient interacted with all of the other employees in the office. So it was inevitable that after the procedure was performed, the doctor would become just one of the other employees working at the shop. All right, here's a little detour talking about mental health. Sometimes you believe everything you did was correct and proper, but the patient doesn't perceive it, meaning that there's a disconnect between the objective outcome and the patient's subjective perceptive outcomes. So, I mean, trying to win this debate on facts may be a losing proposition. I I think it's important to at least pay attention to the possibility that your patient may have a mental health challenge. They didn't see you for a mental health challenge, but some of the reasons they may have come in to see you for may be manifest through a mental health issue. Um, so I would just pay attention to it. You know, typically you just want to make sure that expectations are managed before a procedure is done. If indeed, you know, you're a proceduralist and that is indeed why the patient is unhappy. When I talk about expectations, they're often related to three giant buckets, namely, how much will this procedure cost me, if anything? How quickly will I recover? What is my downtime? Am I going to be able to attend the wedding of my daughter over the weekend, or am I really going to be out for the count for several weeks? And what is the outcome? What is the realistic outcome? Meaning, what's the likelihood of a good outcome? And to the extent there's a potential for a problem, what are the reasonable risks? And sometimes you do need to talk about the worst case scenario because indeed, if the patient experience a worst case scenario, they're going to come back and say, "I had no idea this could happen." And you know, it's a balancing act. How much do you tell an individual, particularly if your track record is excellent? What if your patient is in their 30s and they're going to have a strictly cosmetic procedure? They're in otherwise excellent health. You perform a 5 hour cosmetic procedure. And then 2 days later, the patient dies from pulmonary embolus at home. There was no known risk factor, meaning that you did the proper um, spreadsheet looking at risk factors and you took what were reasonable prophylactic precautions in advance, yet still that patient had the very unusual and unlikely outcome, which is a death. Absolutely horrible. They didn't see it coming, but all surgery can be associated with deep venous thrombosis manifests as a pulmonary embolus. It doesn't, there really are no, 5 hour surgical procedures where that is a risk of zero. It does not exist. And, certainly there are some things that the practice may not have been aware of. Did the patient have a genetic predisposition? I mean, how deep do you go in terms of a family history on this? I don't have a great answer to that. I'm just trying to explain that expectations often need to be managed. And if you are dealing with surgery, you need to talk about the common things that could happen, but arguably also the uncommon but horrific things that could happen. All right. There's also the flip side, which is calling everybody a mental health problem. So sometimes the individual can be labeled as crazy, but before they assume that label from your practice, you may want to do a deep dive. Um, if the patient had an actual complication, meaning they weren't crazy, it's ideal that you diagnose and address that complication. Then they take off and go to a new provider, or you fire this individual. They go to a new provider and then file a complaint to the Board of Medicine because you did the procedure, but you didn't mop up after your own complication. I can tell you an interesting story where the doctor performed a procedure. He did a breast reconstruction procedure after cancer, and patient was pretty happy with their outcome. And objectively, the patient had an excellent outcome. But a year later, the patient was on the internet describing the doctor as money grubbing fool who just performed at the lowest possible level and should have his license revoked, and so on and so forth. Yeah, they'd give them 0 stars on a Yelp review if they could, but it did look like crazy ranting. Um, and so, the doctor was appropriately incensed and wanted to know about getting some type of restraining order and so on and so forth. And then I asked him, I said, is it possible that she has metastatic breast cancer? I mean, the original procedure was for breast cancer, removal of the breast and reconstruction. Is it possible that she has a more advanced stage of the condition with metastatic disease to her frontal lobes, meaning that she became an individual personality-wise that she wasn't previously. So he said, I don't know, because I haven't had any follow-up with her. Let me chat with her primary care doctor. And it turned out she didn't have metastatic disease, but she did have a history of multiple sclerosis. Uh, yeah, MS. So he ended up chatting with a primary care doctor who then coordinated with a neurologist, and she had a flare up in her frontal lobes, which was an explanation for what happened. So by coordinating behind the scenes, they were able to actually help this individual. And turned out she had an organic reason for appearing the way that she did. It wasn't that she was crazy. Well, I mean, she was manifesting as an individual who was not herself. So, yes, I suppose she could be labeled as crazy, but there was an organic and here a treatable reason for why she was behaving. In fact, I would call it an early warning indicator. So, be careful. Yes, there are many people out there whose underlying behavioral issues are mental health related, but depending upon where the patient is in their post-op or post-procedure course, depending upon the type of relationship you have with them, be cautious before they receive the moniker crazy. All right. So when patients go to war, sometimes over money, but sometimes for other things, there's often a hierarchy of escalation. They start off by raising their voice. They are angry. They're angry because they want to be heard. This then goes on to rotten emails, rotten phone calls. Then the online review world sees you as the protagonist evil individual. They may sue you in small claims court because no attorney will take their modest case. They may file a complaint to the Board of Medicine. Why? It's easy to do. It requires almost no effort. It used to require a few minutes of time and actually investing in a stamp and going to the post office. No longer. It just requires going to your computer and dictating in a somewhat incoherent message, and the Board of Medicine has to take all of these complaints seriously, and you will get a letter from the Board of Medicine saying you may have violated the Medical Practice Act for unprofessional behavior, yada, 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 and then you have to respond to it. You'll probably win, but it is aggravating, time-consuming, and unnerving. And then finally, the patient may be able to persuade an attorney that there's a real case here, that there is a real bona fide complication, and they deserve money. And that's the end of the fog of war that is actual war. All right, so let's move on to requests for getting their money back. The world has changed, and um, sometimes the patient has large expenditures out of pocket, and they will ask you to make it right, whatever it is, and they'll ask for their money back. And depending upon the type of specialty that you're in, if you're in the cash pay world, you're not unfamiliar with requests for money, get their money back. If you're mostly in the insurance world, now because individuals have $8,000 deductibles, the first dollar out is the patient's money, and they may ask for some of their money back. So my argument is sometimes it does make sense to give some or all of their money back. Sometimes it makes sense to do extra work, do a revision procedure, etc., where you waive your professional fee. But if you're going to do any of these, you really need to get a release. Why? You want to be done with this. If you're going to give, you need to get. Let me repeat that. If you give, you must get, and you need to do it with a release. And we provide these types of releases at Medical Justice. I would say don't just go to LegalZoom and download a release. You want something that works in your state, that manages all of the problems, not just a legal release, but you want to make sure there's no online mischief. You want to make sure that the release comports with requirements imposed upon you by the Board of Medicine, and so on and so forth. So it's not, I wouldn't call it complicated, but I would say it requires more than 3 minutes of thought. All right, here's an example. In this case, the patient trash talked all the prior doctors, so the red flag, A, B, and C. New doctor walks on water, again, red flag, A, B, and C. has a collection of non-invasive weight loss procedures. Um, wouldn't obviously see the result of that because it was non-invasive. So over time, presumably this would work. She was lost to follow up, did not call, she didn't write, but then eventually she does call and says, you know what? I see no improvement. Practices come in, let's take a look at you. She says, no way, no how. You need to just give me all my money back or I'm going to destroy your practice online. Not subtle, not that I'll write a bad review. This individual said she will destroy the practice online. This is a woman on a mission. All right, so we put together a program. It's called the Disappear Program. It stands for the Definitive Innovative Solution Addressing Pissed Off Patients Expecting a Refund. So the acronym took, by the way, I came up with this acronym before ChatGPT. It probably would have been effortless in the era of artificial intelligence. But the acronym was more difficult to implement than the actual program itself. How do you manage this? So you send a note to someone who has threatened you with destroying your practice unless you give them money. Well, that is extortion. Okay, it is a criminal offense. As to whether a district attorney would take such a case because they are busy dealing with robbery, rape, and murder. Hard to say, but if you have a relationship with the district attorney, conceivably, yes, they would take such a case. It wouldn't be the first time that a case of extortion has been filed and gone to trial, actually, or the patient had pled it out. So anyway, often you just send a note to the patient saying, we want all of our patients to have a positive experience with our practice. But by the way, in the background, well, first of all, I know you're not happy, but you kind of went over the line. What you threatened is extortion, it's a criminal offense. I am willing to resolve this conflict, potentially giving you some of your money back in exchange for a release. What do you say? And often this works because many patients, when they're angry, don't realize they committed a criminal offense. They only believe that somehow the offense is committed if they go online. It's not the threat, but if they go online and actually go to town and destroy your practice. But it's the threat of extortion that makes it a criminal offense. You don't even have to implement it. Certainly, if the patient makes good on their threat, that's additional evidence of their intent to scare you to give them money. But the crime of extortion is committed when the threat is made, either verbally or in writing. It's often better if they make it in writing because it's easier to prove. It's evidence. It's exhibit A in a criminal trial. All right, so let's do a little bit of a deeper dive into the unhappiness expressed by patients with online reviews. And we'll focus mostly on negative reviews. There are these services that are out there that say, we are wonderful in being able to take down reviews, meaning that we've got some type of backdoor channel to Google, or we've got some type of AI mechanism that knows how to flag reviews, and our success rate is 100%. There really are only two ways to get a negative review taken down. The tried and true way, which is the patient takes it down. If the patient agrees to take it down, that works 100% of the time. Or number two, the review site takes it down. The review site might take it down if the review violates the terms of use and you have brought it to their attention by flagging the review. Those are the only two ways to take it down. Also, there are ways to respond to the public. You can respond broadly to online criticism. You need to pay attention to HIPAA. You cannot reveal any protected health information or the acronym PHI. So tread carefully. There's this belief, which is not accurate, that if the patient is already out of themselves with a full story of their medical history, that it's fair game. You're just responding, you're just entering the debate, but you didn't really disclose any protected health information. The patient exposed their protected health information. You're doing a little more than correcting the record, than factually making sure the public knows what took place. But HIPAA does not allow you to do this. The only way for you to disclose protected health information is if the patient gives you a signed authorization. And if they're beating you up online, I doubt they would give you a signed authorization. And even if they gave you kind of this broad signed authorization in advance with a formal HIPAA release, they can withdraw that authorization anytime they want. And then number two is if the statute or regulation provides for a backdoor, no need to obtain the patient signed authorization, and they do exist. So, for example, if a patient is disputing a charge with Visa or Mastercard, saying that no, you didn't authorize the procedure to be performed. Can you respond without the patient signed authorization? Remember, here in this example, the patient's angry. They're not going to give you a signed authorization. So what to do? What to do? Well, it turns out that there is a regulation or an exception. So you don't need the patient signed authorization. It's called the PTO, payment treatment operation exception, which says that if you're fighting over money, in this case, you're trying to reasonably dispute the chargeback with Visa or MasterCard, you can do so as long as you use the minimal amount of protected health information. You disclose a minimal amount of protected health information to get the job done. So, for example, the patient says, no, I didn't have Botox in my face, Botox injection, and they've got a signed authorization or signed treatment plan in the office that they said, go ahead, I will pay, for it. And there's a note which says that indeed the doctor did inject Botox into the patient's forehead. Well, that would be the minimal amount of protected health information that you can and should use to resolve the financial dispute. If you don't need to give the full medical record, I would argue don't give the full medical record, just give what it takes to get the job done. So, for example, if you also know the patient has a history of substance abuse and has genital herpes, that is not necessary to resolve the financial dispute related to the chargeback around Botox. So just, there are ways around it, but getting back to the issue before, if the patient is outed themselves and outed their treatment plan on the internet, you still need to be careful about how you respond. You need to do so without divulging any protected health information. And yes, it can be done. So here's an example, and I've used this in a separate video in the past, but because I think it's a good exemplar of what can be done and how to get your point of view across, I think it's helpful to revisit. So here, Dr. X is a butcher. He botched my facelift and now wants to charge me another $10,000 to fix his screw up. Certainly not a flattering review. And this was his response. Most of our patients are delighted with their outcome. We wish all were. Still, for those who are dissatisfied, we will offer to perform a revision within a reasonable time frame where we waive our professional fee. So notice the language here. They're saying most of our patients, they're not even responding to this patient. They're just giving a generic description of their practice philosophy. They're also describing how they manage an unhappy patient and what the cost might be. There's nothing said about this patient's $10,000 kerfuffle, and I think there's more to say about this. In addition, all it says is the doctor waives their professional fee going forward, in those situations where they may do a revision, not that they've committed to a revision, where they may do a revision. Nothing is said about who pays for anesthesia, who pays for the surgery center. Doesn't even talk about how long the patient has to make their angst known. The doctor will jump in and say, we'll do the revision. And importantly, it states that not 100% of your patients are happy. I mean, this is obvious, but I think stating it, it exhibits a little bit of humble pie, and I think that goes down well to the public. It may not go down well with this patient with a poster, but it goes down well to the public. In this case, the public is your audience. And this is a one and done response. There's no debating. You're not going to go back and forth. The longer you stay engaged and involved in a back and forth um, debate, the more likely you will breach HIPAA and you will create a problem down the road. So your goal is to educate the public, not to win a debate with this individual poster. All right. I've, this is a collection of real responses that I've seen in the past. I advise against it, and I'm just stating this to point out that if you're on the receiving end of a negative review, it can and will make you angry, and there's a tendency to want to lash out and to just get the facts out there. Resist that impulse, sleep on it, don't do it immediately. You don't need to send out that angry email to somebody that insulted you. So here, Ms. X continued to smoke after I advised against it. Yeah, the patient is the villain and responsible for the complication. The patient was not compliant with my recommendations. Patient missed all the post-op appointments. So, I mean, yeah, I mean, here you're basically pointing the finger. Of course, she had a complication because she didn't follow the guidebook. And then this is a real one. Ms. X is a despicable, money-grubbing, subhuman being. I wish she had never darkened my doorstep. Well, the mere fact that you've disclosed that Miss X was your patient, much less a despicable, money-grubbing, subhuman being, is a disclosure of protected health information. It doesn't take much to cross the threshold to disclosing protected health information. Even acknowledging that an individual is a patient is such a disclosure. So people have asked me, I said, well, is it responding to a review broadly an acknowledgement that that this individual was your patient? Well, maybe, but I've never seen a physician be beaten up by the HIPAA police, that would be the Office of Inspector General for Health and Human Services, for just telegraphing a generic message about your practice philosophy. You're not really talking about that individual patient. You're just describing kind of broadly how you manage problems. Guiding mantra, I was a surgeon for quite a while before I moved over to the legal world. And the solution to pollution is dilution. This works in the surgical world. If you have a wound infection, you want to dilute it. You want to irrigate as much as you can to get the bugs out. Yes, those are real surgical terms that we use. But it also works in the online world. So to the extent the voice of your happy patients can be placed on the internet, do it. They're less inclined to want to post, but if you make it easy for them with a point of service system, yes, we offer a point of service system called eMerit, but there are others that are out there. It catches them at their happiest moment, and it allows you to allows your patients, your happy patients, to populate the internet with their stories. Don't filter. I mean, I would be cautious about giving such an iPad to patients if they have smoke coming out of their ears, but we generally tell our doctors don't filter reviews. But just make a review service available to them so it's easy. Once they go home, once your happy patients go home, they really have moved on. They are not, I mean, you can send them links and reminders, but if they're happy, they've kind of moved on to the next challenge in their life. And they're like you and me, they're busy and they've got other things to do. All right, so let's wrap up. If you touch a patient, either as a clinician or the surgeon, you've bought that patient. So be careful when you are interviewing each other. Identify problem patients before you accept them into your practice. Mental health issues abound in in our era. Just pay attention to it. And also, the flip side is also true. Before you label a potential patient as being crazy, at least be open to the idea they may have an organic problem, which is fueling a behavioral manifestation. And then finally, I think this is the best news of all, is that most conflicts with patients can be resolved. And you may not feel great about how you resolve them. You may feel like you need to take a shower afterward, but by and large, I do think there are solutions to most of these. You can still continue to practice good medicine and you don't have to question whether your career choice was a good one. So with that, I thank you for your attention. If you have any questions, you can reach out to me directly. That's jsegal at medicaljustice.com. Again, jsegal at medicaljustice.com. And we've got a QR code on the bottom as well as the end of the slide deck, which makes it quite easy to either submit a question by email or to set up a short consultation if you'd like to speak. And finally, we've been at it for a while. We've got over 2 decades of experience managing challenging patients and the conflicts that come from them, including litigation, data bank, medical board complaints, and so on and so forth. But we'll have more of these videos out on how to manage the human end or the legal end of the practice of medicine. Thank you so much. Until we meet again.